again, good morning, colleagues. I have less than 19 minutes to just recap on the clinical spectrum and risk factors, including predictors of poor outcomes for those with COVID-19. I'm sure, Prof will look at this, both professors will look at this in detail, possibly look at the structure of the SARS-CoV-2, which has the spike protein, the nucleocapsid protein, and also the genetic material, which is the RNA. The transmission, Dr. Nyambe did go through this, and largely just to emphasize that the transmission is via aerosols and also the droplets. In terms of the pathophysiology, we know the pathophysiology is closely linked to the symptoms that the patients do present with. We know that there is an early infection stage, then also the respiratory phase, and also the hyperinflammation phase. And even the treatment is also aligned to that. In terms of the clinical symptoms, in the early phase, you may have lymphocytes going low and also mild constitutional symptoms with cough and also fevers. Then as the inflammatory response kicks in, then you have also the severe symptoms also kicking in as well. And on the clinical side, someone will present with a shortness of breath, they will be hypoxic. And we had seen this especially during the Delta and also the Beta waves, which we ran through as a country and in fact as a globe. And also the hyperinflammation phase, those that reach that stage, they are severely ill with ARDS and also shock, cardiac failure, which will be able to be seen as well. But this is an exaggerated hyperinflammatory response at this stage. Then this discussion will be done largely in the afternoon, looking at which drugs can be used at different times, and this is aligned to both the viral and also the inflammatory response, with the use of antivirals in the early phases, and also use of the immunomodulators to dampen the inflammation. This discussion will be largely done during the sessions looking at the treatment. The testing, Dr. Monze will cover the testing, but in this just needed to highlight that the main diagnostic means which we have the nucleic acid-based testing and also the antigen-based testing. And these are available in country as well, with the antigen-based testing widely used. We are not using the home-based testing in our country, but we are largely using the antigen-based testing in facilities. And we also have the nucleic acid-based testing almost in all the regions in the country, with, of course, high sensitivity with the nucleic acid-based testing. But specificity is also good for the antigen-based testing. And we do encourage that those that have a negative antigen test, you do have to repeat and also go for the nucleic acid-based testing if there is a high index of suspicion where there is clinical disease and also there was if there is exposure to someone with SARS-CoV-2 as well. The serological testing, these we are not usually using them for any medical decisions. We have used these largely for people who are traveling. There are certain countries that want to use the antibodies as a marker of either previous infection or also a vaccine. But largely this is not used for making clinical decisions. And when you come to the symptoms, the common symptoms, we still have fever, dry cough, fatigue, which is a hallmark of this disease. Then we have in severe disease, people may even have hemoptysis, which is rare, but also you may have lymphopenia during that stage. We have the less frequent symptoms, nausea, diarrhea. Anosmia apparently is also quite high, and also the loss of taste, as well as anorexia. We currently have these two patients that Dr. Chitanika will possibly maybe highlight on one of them. These are currently admitted in our hospitals. You see that there's also COVID lung disease, even right now, affecting our people. These are in ARDS, and they are on immunomodulators, something which will be discussed later. So we still have COVID affecting the lungs, and especially in those who have risk factors for progression to severe disease, and these are currently in admission in our hospitals. But also, we have these extrapulmonary manifestations of COVID-19, which we need to look at. The GI is affected. You also have the endocrine systems affected. The kidneys are also affected. You can have AKI. You also have the musculoskeletal systems affected. So generally, wherever you have blood vessels, you find that there will be this inflammatory response generally in the whole body. So that's why you have these extrapulmonary manifestations of this disease. Classification for WHO, revised one, is based on either someone has non-severe disease or severe disease, and also those that are critical. So non-severe are where you have absence of signs of severe or critical disease. Then the severe disease are those who have oxygen levels are below 90%, and you have signs of pneumonia and also respiratory distress. Then critical are those that may need life-saving treatment. There will be on ventilation, people who have ARDS, and also those with sepsis and septic shock. We largely now have a number of cases that we are seeing, especially with the Omicron variants and also the subvariants. We are seeing mostly non-severe symptoms, but we see a number of people as well progressing to severe disease depending on the risk factors. This we are using the pulse oximeters largely during the pandemic, but also they have limitations. They can, sometimes you may not detect hypoxemia accurately, especially in those of us who have dark skins, where you have skin pigmentation is dark, and also if you're using a nail polish on the nails as well. So what is more important really, even as we get the oxygen saturation using the pulse oximeters, is to marry the symptoms with which the patient has presented with, and also the signs. So if someone has dyspnea, someone is tachypnic, there's chest pain, also there are mental disturbances as well, and if someone is nosed, those are factors that should be considered, even if you may have, even if someone has oxygen saturation levels which are high. So it's important to marry this with the clinical presentation of the patient. And also importantly that usually we find that these individuals who may need, especially those that have desaturating, they are anxious, they have to be calm. You have to stop them from talking for several minutes for you to get an accurate reading. We have looked at risk factors even here for progression to severe disease, and what we can say is age is the major risk factor. With those above the age of 60, it's a range, 50 to 65, as a major risk factor for progression to severe disease. But also the vaccination status, this has been seen even with our data as well. Vaccination status is important. Those that are not vaccinated have a higher risk of progressing to severe disease. Those that do not have early treatment as well, especially with the antivirals which we have, they may likely progress to severe disease. Then presence of comorbidities, diabetes, hypertension, cardiac diseases, those that have chronic lung disease, chronic kidney disease as well, and people who are immunosuppressed, either with HIV, those that have malignancies as well. But pregnancy is also a risk factor for progression to severe disease. But importantly as well in the pregnant population, just to highlight that increasing maternal age in that population is also a high risk factor, a high BMI, and the other pre-existing comorbidities if they are present, especially gestational diabetes and also preeclampsia. So this population has to be looked at closely. We looked at the factors associated with severe disease. We looked at HIV. What we found was that those that had uncontrolled HIV were at higher risk of progressing to severe disease. Those that were age above 60 years also had higher risk of progression to severe disease, and those that had comorbidities. So uncontrolled HIV was a high risk factor we found for progression to severe disease. There are things also that we need to, of course, bear in mind when it comes to the other complications in patients with COVID-19. We have the co-infections at presentation, which need to be managed, like influenza. I'm happy Dr. Monze will be highlighting those other co-infections and also other respiratory viruses, because someone may have COVID and also may have those co-infections. Bacterial pneumonia is also a possibility, and we don't need to give antibacterial therapy. However, there are certain indications if you see that the leukocytosis, the presence also of infiltrates on imaging, those may guide you on the use of antibiotics. But there's also other conditions we need to be aware of where there's reactivation of latent infections, hepatitis B, TB, herpes simplex viruses, then varicella zoster as well. These may reactivate if you are putting someone on immunomodulators, the drugs which we'll discuss in the afternoon as well. And you have seen that some people routinely even use ivermectin because of the high risk of strongyloides in the patients that are treated with tocilizumab and also the steroids. So it's not for treating the COVID, but to treat the strongyloidosis in patients that may come from the endemic regions and also that may live in endemic regions to strongy. Now, this is not routinely done in all the centers, but I know there are some centers which routinely give ivermectin because of that high risk as well. But nosocomial infections are also common in those that are hospitalized. We need to look at how do we prevent them, but also fungemia is another thing which we did observe, especially during the peak of the pandemic. If someone starts deteriorating, fungemia is a high consideration, but also catheter-related or associated urinary tract infections, including Clostridium difficile. So C. diff is another area because of the use of antibiotics. We saw this during the peak of the pandemic. Also need to look at other opportunistic fungal infections, invasive fungal infections, including aspergillosis, mucormycosis as well. And this is largely in those that are on immunosuppressants or those that are receiving mechanical ventilation as well. So we need to evaluate the patient in totality, especially those that are admitted for a longer period of time, so that you can prevent any of these infections around. Reinfection and also breakthrough infections are a possibility. Possibly Prof may touch on those for those that are vaccinated. And however, the time to breakthrough infection, which has been reported to be shorter for those patients with immunocompromising conditions as well. We have, of course, prolonged viral shedding, which has been recorded. We've recorded even us here, prolonged viral shedding for those that are immunosuppressed, those that have HIV compared to those that do not have HIV. The other markers which can be used if you have a patient with COVID-19, especially those that are admitted, to look at the as prognostic markers, IL-6, Then the D dimers suggesting any underlying coagulopathy, serum ferritin to look at the inflammatory response, but also lymphopenia is a marker of severe disease, including CRP. And the CT scan of the lungs, even an X-ray, can also show a progression to severe disease and also as a prognostic marker. So right now, even if we are not seeing majority of the cases with severe disease, we need to have a plan, especially for those that are at high risk of progression to severe disease. Importantly, vaccines have to be given, someone has to be prepared and to have an update in the COVID-19 vaccine, and also improve ventilation when possible, and just make sure that people know where to go for when they are sick, and make sure that they are also able to access the testing and the hygiene parameters which are available. So really an emphasis on those people who are at high risk of developing a severe disease, both prevention and also early treatment is something that we need to embark on. Thank you so much.